tolerable treatment. In fact, the dropout rate was only 3% in this arm. Thus, we have very effective therapy for this group. Now, for genotype 1, the story is a bit different. 24 weeks did not perform as well as 48 weeks, and higher dose ribavirin appeared to be critically important. 51% of patients getting higher dose ribavirin for 48 weeks had sustained virologic response. Thus, the standard of care today is genotype 2 or 3, 24 weeks, lower dose ribavirin. Standard of care for genotype 1 is 48 weeks with higher dose ribavirin. So, clearly, genotype has evolved to have an important role in managing patients. Now, one of the problems with higher dose ribavirin is the development of a dose-dependent hemolytic anemia. When you give ribavirin, it's taken up into RBCs. The red blood cells are then marked for destruction in the RES, and there's a brisk dose-dependent hemolysis. What you see within 4 weeks of starting combination therapy is about a 2.5 gram hemoglobin drop. Some patients, about 10% of men, lose 5 grams of hemoglobin in the first 4 weeks. Interferon suppresses bone marrow. So one of the big problems with treatment and the use of ribavirin is anemia. One of the things that we've learned through randomized controlled trials is that EPO is effective in reversing interferon and ribavirin-induced anemia. Now, you might think it wouldn't work in the setting of hemolysis since it stimulates the bone marrow to make more red blood cells. In patients randomized to receive EPO at the 40,000 IU sub-QQ week, a 2.9 gram increase in hemoglobin compared to standard of care. What's important in this group is they were also able to take more ribavirin. So EPO sustained both hemoglobin, but also sustained ribavirin dosing, and is hypothesized to lead to higher sustained virologic responses. The downside to this is extra cost. EPO is not a cheap drug, neither is PEG interferon alpha 2A or 2B plus ribavirin. Now, what's really driving treatment today is side effects. I mentioned one of them associated with ribavirin. But if you told a patient, I've got a medication that has a 50% chance of eradicating your virus, why wouldn't someone want to take that medication? It seems like a no-brainer. Well, the reason is because of toxicity. And most of the patients I see have already been to the internet or read the package insert for these drugs, which can be quite a daunting experience. But I think the side effects can be broken down really into several buckets, if you will. The first is a flu-like symptom in the first 3 to 4 shots. Patients have high fever, up to 102, muscle aches and joint aches. These tend to resolve after the first month due to tachyphylaxis and can be treated with ibuprofen or acetaminophen. What's probably more daunting is fatigue. As many as 75 to 80% of patients complain of fatigue. They have difficulty doing the things they need to do, although most patients are able to work. The next category is interferon brain effects. Interferon does cause depression, it causes insomnia, it causes an irritability that's almost universal. People get a bit cranky, at least in part from being fatigued, but in part due to the effects on the brain. These effects do respond to serotonin reuptake inhibitors, and insomnia can be treated with things like trazodone. I would not recommend the use of things like Ambien or benzodiazepines. They don't work very well in this context. But between fatigue and neuropsychiatric effects, that accounts for the reason why most people in the treatment are very glad that their treatment course has been completed. There are other effects worth mentioning. One is alopecia. About a third of patients have hair thinning. They do not go bald from the thinning of their hair. There is also neutropenia and thrombocytopenia. Now, neutropenia is common, as many as 20% of patients go below 750 ANC. That can be treated with G-CSF. Thrombocytopenia is only an issue in cirrhotic patients, but sometimes limits therapy. The other one worth mentioning is that about 1 to 2% of persons will develop thyroid disease. Now, this is obviously more common in women, but I tell all my patients about it because this is potentially irreversible. All these other things, when you stop therapy, go away after 4 to 8 weeks. However, some patients do require Synthroid indefinitely due to hypothyroidism induced by the interferon. This is an autoimmune type process. Another tool to limit toxicity, I mentioned one with the use of SSRIs and EPO, is week 12 predictions of response. I mentioned earlier that when someone responds, it doesn't take a long time to tell. And in fact, within 12 weeks, if the person you're treating has not dropped their hepatitis C viral load by greater than 2 log 10, the odds are less than 1% that they will obtain a sustained virologic response. A very high negative predictive value of about 99%. So you can tell a subject who's failing to respond in week 12, we can stop therapy because there is a less than 1% chance you'll achieve virologic response. On the other hand, the person that's responding has a fairly high positive predictive value, about 70 to 80% that they will achieve a response. So one of the things that you'll see in practice today is stopping patients who fail to respond at week 12. Now, there is a role for continuing treatment of those with advanced disease, oftentimes dropping ribavirin. This is known as maintenance interferon therapy. Now, which patients should be treated? Well, today all patients are treatment candidates, but the biopsy plays a crucial role. Patients without fibrosis, that is no scar on liver biopsy, can safely defer therapy. The ALT is not an important determinant of who should be treated or whom can safely defer. A biopsy is the most important tool. The biopsy is what tells a patient their prognosis. I would, however, suggest that we can treat patients with genotype 2 or 3 without biopsy, and we now routinely offer our patients treatment if they want it. Now, I mentioned acute hepatitis C treatment. If you find a healthcare worker who acquires hepatitis C through a needle stick, there is strong evidence published by Jackal that treatment in the first 6 months can lead to eradication of virus and prevent persistent infection. In my view, the standard of care today is to get a hepatitis C RNA in that healthcare worker 4 to 6 weeks after exposure and consider treatment with interferon or interferon plus ribavirin. There are a lot of unanswered questions, but treatment needs to be considered. The other group where treatment needs to be considered is HIV-infected patients. The era of HIV/AIDS is now a manageable disease. The recommendations are that all patients should be screened and that treatment should be considered on a case-by-case basis. And in our clinic here at Johns Hopkins, 50% of our HIV patients have hepatitis C, and our efforts underway to try to treat these individuals as much as possible. Now, I mentioned future therapies. We're nearing the cusp of a very exciting time in hepatitis C. There are specific small molecules being designed to target the virus. Hepatitis C has a RNA polymerase, the NS5B region. There are now, in human beings, early studies of polymerase inhibitors. These are drugs that are designed to target this region. In addition, there have already been exciting data presented at the liver meetings last November about a protease inhibitor. The same target, albeit a different amino acid protease, that was so successful in HIV that attempts to duplicate in hepatitis C. In fact, in a small study of about 20 patients, a serine protease inhibitor from Boehringer Ingelheim induced a 2-log drop in patients in only 2 days. We're looking at trials coming down the pike in the end of 2003 and 2004. Very exciting times for hepatitis C, although we expect the virus to become resistant to these pathogens. And we're planning for that, not unlike the situation with HIV. So today, as I alluded to, the standard of care is peg interferon ribavirin. Genotype 1, clearly more difficult to treat. You can quote a patient about a 45% probability of sustained virologic response. The treatment is for 48 weeks. Genotype 2 or 3, you can quote an 80% probability of response for only 24 weeks. The other key to success is aggressive toxicity management. The other key, at least in the United States, is increasing access. There are high numbers of patients living in Baltimore who are not getting treated. There are a large number of patients in prisons and other settings that are not receiving care. In fact, it's estimated that only 1 in 10 hepatitis C infected patients have been treated for hepatitis C. We need to do a better job screening patients and considering therapy. We look forward to new treatments, but they are 4 to 5 years off from FDA approval.
Dr. Sulkowski concludes by answering questions.
A few weeks ago, I heard a physician posit very persuasively that most people who are being treated for hepatitis C don't need to be treated. Do you concur with that?
I think the issue is in patients with minimal liver